wouldn't have happened, and we're just incredibly grateful for Harriet Smith, her colleagues, and for helping get us all together for what I hope will be a really, really important discussion. So huge thanks to you and to everybody in the Academic Health Sciences Network for putting this on. We appreciate it very much indeed. What we're hoping to do is just see a real transformation in asthma care through the new available systems, and it's lovely to have this opportunity to begin to build that. So I am going to go quiet because I can see that Ian is there and just waiting for me to shut up. Story of his life, probably waiting for me to shut up. And I will pass over to him and welcome everybody.
Thank you, Ian, for the few kind words. Harry, are my slides on there, or do you want me to share them? I can do either. I'll share them. There's a curse of Teams, isn't it? Can everyone see those slides?
Yep, we're good. Thank you.
Yeah. Perfect. So, say thank you to Ian for that little bit of introduction there. I'm Ian Clifton. I'm a respiratory physician at St James's, and I've got a particular interest in severe asthma, but also all aspects of asthma care. So welcome. And firstly, although Ian has thanked everyone organising this meeting, I would like to pass on my thanks to Ian as well for, well, two things really. One is organising this meeting and I think driving this meeting forward. I think it's an exciting agenda, and hopefully I think we can get out of this some really positive steps for asthma care in the future. I think we should use this as a launch pad. But also I'd like to thank Ian for his support over the years in terms of the Yorkshire Asthma MDT, which we've run now. I can't remember how long for, but it feels like 7-8 years maybe, which I think certainly at the severe end of the spectrum has really helped transform asthma care across the region. And Ian has been one of the driving forces in that YMDT, and I think I'd just like to say a massive thank you from me personally, but I suspect all of us in the region and all of our patients for his dedication towards that over the years. So thank you. So I kind of had to eliminate all the usual things about fire alarms and toilet breaks and things, and so I thought I'd get straight into things. And I was thinking about this in terms of what are we trying to achieve here, and for anyone who's interested maybe in transforming asthma care, I think there's some useful stuff that came out of Finland, and probably it's slightly embarrassing that this is now probably 20-30 years old, this information, but it is, if you're interested, it is worth reading and going back and reading those papers about the national Finnish asthma program, and maybe we should try and develop something along those lines in Yorkshire. And one of the key things they focused on was early diagnosis and active treatment, big focus on self-management, which I'm sure we'll hear about, reduction in respiratory irritants and smoking, and actually a concentration at the kind of public health and legislative level of legislation around limiting tobacco exposure. Huge amounts on education for patients and rehabilitation of patients at the appropriate times, and a big thing about education for key groups of staff and patients. And then connected to all of that, I think, was a kind of promotion of scientific research alongside asthma care. And I kind of think this is something that we could maybe well learn something from in Yorkshire, and hopefully we may start this ball rolling this afternoon. And they focused very much on the people with asthma, and then the kind of carers around that individual with asthma. So pharmacists, GPs, primary care nurses, secondary care physicians, specialist nurses, smoking legislation I've mentioned, diagnostics. So there's a real big focus on a kind of system-wide change to deliver good quality care for people with asthma. And I think it's probably something that we can maybe learn something from, is that I always feel, not always, but sometimes in the NHS, is we operate in little silos. and we don't necessarily see the kind of broader picture. We need to link things up, and actually sometimes the patients get slightly frustrated with us because it's kind of you're directed to one bit or another bit, and there's not necessarily that communication. I hope that we can this afternoon maybe break down some of those silos and have a really good discussion about communicating across the whole spectrum of asthma care, because I suspect we all are interested, and this is something I think is very important. And just very briefly, as I say, I'm going to be very brief in my welcome, because I think it's more to the discussion from other people to really move this on. But actually, what were the outcomes from this? And they transformed asthma care really in Finland over this kind of 10-year program. They found a lot more people with asthma, so they went from having a prevalence of about 83,000 in the country to nearly 250,000. So they found patients who were not being treated because they hadn't been diagnosed with asthma. And I can imagine our commissioners getting very worried about this and thinking, well, that's going to just increase up our asthma costs, and we're going to be treating more patients and more drug expenses and things. But actually, the converse happened, and the cost per patient of asthma care reduced by about 50%, from just over €1,000 to €500 per patient. And that's a really important thing to kind of also factor in there, is that we know that healthcare inflation increases. So actually, that kind of reduction is probably a very meaningful reduction in healthcare utilisation. Unfortunately, I couldn't find any data looking at the kind of green impact, and I know that's something that we're talking about from Finland. I would imagine that if you're spending less euros, you're going to be producing less carbon dioxide. So I think it's a surrogate marker, but I wouldn't want to absolutely confirm that. And then thinking about things that are important to patients. So coming into hospital, and I know that asthma deaths are a relatively rare event, thankfully, but when they happen, they can be absolutely devastating obviously for the patient, but for the family and friends. And they found that they were actually getting on top of this, and asthma deaths in Finland now are a very, very rare event, and I would suggest probably a lot rarer than we see in the UK. So I think there's a lot of stuff we can maybe take from Finland, and I think the key thing is about doing the basics well, and getting that systematic approach so that everyone has got a consistent approach to approaching someone with asthma, but really getting those basic issues there sorted and addressed. And I think we'll touch on a lot of that later on this afternoon. And this is my last slide, and I think this is hopefully what we're kind of thinking about here, is about system change. And I think the NHS is phenomenally good at doing kind of small projects and getting things going. And I think it's less good, and maybe that's a kind of a harsh criticism, but I think it's less good at sharing and disseminating that learning and resulting in system change. I think we're very good, isolated pockets of really excellent care, but it's then trying to really roll that out across a whole region. And I know that there are people doing all sorts of fantastic things in Yorkshire, delivering really high quality, excellent asthma care, and it's really about trying to drag us all up to the level of excellence. So on that motivational note, that is me. Thank you very much. I think next is Catherine, I think. Is that right?
Hello.
I will stop sharing.
Okay. I'll share my slides and hopefully it'll work. Can everybody see that?
We can.
Yeah, great. Thanks, Ian, for that introduction to today, and thank you everybody for having me speak today. For those who don't know me, I'm Catherine Hickman. I'm a GP working in Bradford and respiratory lead for West Yorkshire and some various other roles as well. But today we're talking about integrated care and what it means to me. I had my appraisal yesterday, and I put in my PDP that I wanted to actually find out truly what integrated care system was, and find out more about West Yorkshire Health and Care Partnership. And I was pleased that my appraiser, who's embedded in West Yorkshire Health and Care Partnership, said It didn't quite say it like this, but it kind of said that we're all kind of winging it and finding out what it truly is. And I think this will be a learning experience for everybody. So rather than me try and explain what a health and care partnership is, and hopefully I can move my slides on, I'm going to show a little video from the King's Fund about integrated care systems.
I'm not getting any sound. I don't know if there's supposed to be some.
No, I'm not either.
Okay, it's probably because of the settings, isn't it?
Probably.
Okay, not to worry, not to worry. I will. I'll talk about it. Right, let me just go back to my slides. So the concept of integrated care system is that everybody is working together and sharing budgets. And as Ian said, it's not about working in silo, it's about social care coming together with public health and primary care and secondary care, and all fitting together a bit like a jigsaw. And I love this analogy of the jigsaw, especially as because we're talking about asthma care today. And very often when I'm talking about making the diagnosis of asthma, I talk of it a bit like a jigsaw puzzle, and you're building up that picture and putting all the bits of the jigsaw piece together to ensure the patient gets the right diagnosis, gets on the right path, and goes forward with their asthma care, and not falling over the cliff edge and ending up in hospital in extremis. And what I also love about this is the fact that right at the center of this joined up model is people centered. And I think it's so important that we keep this at the forefront of our mind, because actually what matters here are our patients and the people with asthma or COPD or other respiratory conditions, and how can we work as a system, all working together to provide that excellent care for not only a population but also for individuals. And one of the things for integrated care systems that is transformational, hopefully, is that we will be sharing budgets. And again, it's not about that silo working, and you know, it is about sharing those ideas, sharing the budget, and all working together to improve the care of our patients. So what does population health management actually mean? So there's no specific definition for population health management, but the King's Fund have come up with a vision. Health outcomes and inequalities in health in England will be on a par with the best in the world. This will be achieved by a consistent and coherent focus on population health locally, regionally, and nationally. And we know in recent years, health policy has focused on the funding, organisation, and delivery of services with insufficient attention paid to population health outcomes and the factors shaping them. Progress has mainly been measured by how the system is performing rather than by the health of the whole population. The first step to achieving this vision, therefore, is to set a small number of ambitious and binding national goals to drive improvements in population health, including reductions in health inequalities. And I know we're going to be talking about health inequalities later. And their vision for population health is based on these four interconnecting pillars. And we know there's a wealth of evidence that the wider determinants of health are the most important driver of health. In addition to income and wealth, these determinants include education, housing, transport, and leisure. Equally, our health behaviours and lifestyles are the second most important driver of health. They include smoking and alcohol consumption, diet, and exercise. And we know that there's now increasing recognition of the key roles that places and communities play in our health. For example, our local environment is an important influence on our health behaviours. while there is strong evidence of the impact of social relationships and community networks, including on mental health. And we must never forget that it's not just about physical health, but it's also about the mental health of our patients. And recent years has been about a really strong focus on developing an integrated health and care system. And this reflects the growing number of patients with multiple long-term conditions and the need to integrate health and care services around their needs than within the organisation silos. But every population is made up of individuals. And if we take Yasmin does not care about that jigsaw picture. She doesn't care about the integrated care system or the QOF or the tick box exercises or the IIF funding. She cares about her. And it's all about what matters to Yasmin as an individual. Not what can I do for you, but what matters to me. Yasmin is isolated. She doesn't speak English. She's lonely. She doesn't know what's going on in her airways. She's been given inhalers that she doesn't know how to use. They don't seem to be making any difference because she's got an MDI there and no spacer. She lives in a damp house. She just wants to get back to singing with her friends and walking her dog. And she's got a phone, but nobody's shown her how to use it. And the video links that she sent don't seem to open when she's had an asthma review. And nobody's truly asked her what matters to her. And I think, to me, with any integrated care system, it's Yasmin that matters. And actually, people like Yasmin and all the other patients out there need a voice. And I think we are privileged in the sense that we have a voice, we have a platform to spread our message, but I think sometimes we can find ourselves in a bit of an echo chamber. The people all here today and so often at educational events that we all do and I do are always the same people who are always doing that fantastic work, but not always the people that haven't got that interest in respiratory. And patients are very often not there and are not always given a voice. And without that patient voice, that jigsaw puzzle falls apart because they're the people living with asthma and living with COPD, and they're the ones that we need to listen to first. And I was listening to a podcast the other day, and it was talking about lived experience and the importance of getting, well, it was talking about, members of society who don't always have a voice. For example, people who are homeless. Who do we get to talk about homeless? We get the chief exec of a homeless charity, but we don't always get somebody who has lived experience of being homeless. I have experience treating patients with asthma and COPD, but I have no lived experience of that. I don't have asthma. I don't have anybody in my family who has asthma. I need to hear from patients with asthma who have lived experience of that. And I did some digging on the internet and found a group of dietitians down in Somerset who have started running for a while patient webinars on gastrointestinal conditions such as celiac disease and IBS and inflammatory bowel disease. And they're also running podcasts. So they're specifically for patients, and also podcasts for where they interview patients with lived experience. And for this year's PDP, I've also put down patient webinars and podcasts for patients in Yorkshire. Thank you very much.
Thank you very much, Catherine. Inspiring as ever. So I think we'll move swiftly on, and I think links nicely into Glenos Jones's talk on looking at inequities and variance and the challenges that we face within Yorkshire, I guess, and the wider.
Can you see my presentation, Ian?
Yes, I can.
I can't, so I'm having.
You might just want to put it on slideshow mode.
Slideshow, yeah.
Yeah, it just needs to be shown as a show, but we can see it.
Is it coming up now?
Yeah.
As a slideshow?
Sort of. Nearly.
There we go.
Yeah, it is now. Perfect.
Yay.
Perfect.
Thank you so much for inviting me to talk at this really important event about a topic that I'm, as you all know, very passionate about. Inequalities and health inequalities in particular aren't just facts and figures for us, and those of us in the audience will recognise that, you know, we have lots of patients in our clinics, lots of people that we know struggle with these day to day, and really it really impacts the people that we see in our clinics. Every single clinic I have, there's something to do with health inequalities that springs up. So what do we know about asthma care and inequalities? Well, we're absolutely certain that people in certain groups suffer excess morbidity and excess hospitalisation compared to majority white population. We absolutely recognise that for some communities there are some very real cultural misconceptions around the diagnosis and treatment of asthma, and a stigma attached to receiving the diagnosis, which can impact on access to care. We all know that asthma requires self-management, and when it's done well, as was shown in Ian's slides from the Finnish study, it's brilliant, and it's much harder to embed in groups where health literacy is low, and for those who struggle with language barriers as well. And this is something I absolutely recognise, because when I set up my own clinic at Dewsbury, I recognised that there would be an ethnically diverse population I'd be serving, and not everybody would speak English, but there's a real lack of resources to cater for people who don't communicate or read in English. In fact, and this is something that often surprises people, 1 in 6 patients in England, 1 in 6 people in the general population are functionally literate. What that means is that they can read things that are very familiar, birthday cards, recipes, but if you give new information, inhaler instructions, peak flow action plans that are very detailed, pamphlets about dysfunctional breathing, people really struggle. And how often do we ask our patients if they can read when we meet them first in clinic? And it causes great problems. You know, I was on call this weekend and there was a Polish lady who had had 3 nights in hospital, 3 nights she'd had away from her family, and suffered for months with poorly controlled asthma because nobody had taken the time to explain what her inhalers were for, how she was to take them, and what was going on. I think there is a growing recognition that this is an issue, and this is a paper from March of last year from the UK Severe Asthma Registry, where they comment that there's a paucity of people from non-Caucasian backgrounds receiving biologics, and that there may be cultural and language barriers that inhibit people coming to treatment. This is a paper from October last year from Leon Hemaney's group, and they purport that there may be distinct phenotypic presentations in people from certain ethnic groups as well. But I think it's a much more complex issue than genetics and inflammatory biomarkers. I don't think there's ever been a better time than this to seek change. And, you know, many things have happened out of the, you know, distressing, awful, hideous time we've had with the pandemic, and also movements like the Black Lives Matters movement, really bringing inequalities into people's minds. And I've noticed, I've been sort of working in this tricky field for about 5 years, and I've really noticed a shift in the last year or two. People are now happy to have conversations. Our very own Ian Sabrero co-authored a paper in the RJ, which I heartily recommend anybody who's interested has a read of, because it recognises that we are having discussions publicly that we wouldn't have had before, and recognising that social cultural factors really genuinely affect asthma and people's health. Why aren't more people doing it? Well, I don't mind sharing with you that it's really, really tough. It takes a lot out of me to do this work. And a lot of that's around, you know, the ugliness and the shameful behaviours that I come across when I'm trying to change things and to move things forward. Prejudice and racism is deeply embedded at a systemic level, but we have the opportunity with the inception of the new ICS and lots of other things to really try and create a space for encouraging change. And I think in terms of doing that, I think we do have to accept that all of us at one time or another will have been complicit with injustice. And that's distressing. You know, it genuinely is. You know, we haven't been able to give people information in a way that they can access. We haven't been able to recognise, because of a lack of cultural competence or busyness or whatever, that people have cultural misconceptions around their care. And I think genuinely it's that distress that motivates me to continue with the work that I'm doing. I couldn't do that work without the support of our Yorkshire Asthma MDT, it really does feel like a joint venture for me. And much as there's some really ugly things, you know, embedded in society and systems, I think within the Yorkshire Asthma MDT, we have a real ethos of inclusivity and kindness. It doesn't matter how you define kindness, either academically or philosophically, any definition does make me think of Ian Sabrero, and I genuinely feel that that's going to be his lasting legacy to all of us in the region. He's inspired us to be kind to each other and to continue through that, to be able to be kind to our patients, but also to be working together extremely collaboratively and supportively. And when you go to national meetings, and I have been doing that a bit more recently, I think it's recognised across the UK that we work in a very special, very collaborative way up here in Yorkshire, and I think that improves our patients' experience, certainly improves our experience as clinicians of working together. I genuinely would like to take a moment to think about celebrating our successes here in Yorkshire in the field of inequalities. You know, it's a rolling agenda item on our bi-monthly meetings. I'm not sure that happens elsewhere. We're continuing to work in a hybrid fashion, and for many of our patients, just continuing to work with non-face-to-face platforms is extremely helpful for our most socially deprived patients. I had one of my biologic patients who has learning difficulties and cares as a single parent for a disabled child tell me that she was so grateful before Christmas that I'd telephoned her, agreed to telephone her and not bring her into clinic because she couldn't afford the bus fare because she spent all her money on presents for her son for Christmas. And, you know, I've got patients who have to take time off work at 0-hour contracts, who have to decide between coming to clinic and buying food or electricity. So, you know, it's a really fantastic thing that we're doing and continue to work in that way. Globally, we were the first region to initiate biologics at home, and many of our patients now are on home care. That minimises travel time to hospitals, the cost of travel, the risk incurred in terms of travelling on public transport for some of our high-risk patients are catching things like COVID, and also not having to take time off means a great deal to our patients. And I think that's something that we need to appreciate. It doesn't always, you know, spring to mind, but actually, you know, for some people, there's an inequity of access due to geography, and plenty of evidence springing up to suggest that your distance from an asthma centre can negatively impact your care. So you're far away, you get less well looked after, and that might be a multifactorial issue. I genuinely think, especially over the last 12 months, that as an MDT, we're sort of changing in our narrative from talking about hard to reach populations to us recognising that we need to get a dance like better at reaching the populations are there. We need to get better at them. And similar to all the other people that are going to be talking today, we need to come out of silos to do that. We can't do it in isolation on our own. And I've really genuinely enjoyed, it's been a steep learning curve, but I've really genuinely enjoyed working with partner agencies recently, and a huge thank you to them. You know, what I've learned from working with people from public health, individuals in the CCG, the Academic Health Science Network, pharmacy teams, all these people have really helped improve my understanding of what's going on and my access to my own patients within the communities. Somebody's going to talk, I'm sure, later on about proactive identification of severe asthma. And again, going back to the Finnish study, you know, we've seen that there's a huge benefit to proactively identifying people. Under referral isn't a Yorkshire issue, it's a global issue, and it's people are more sensitive to it who are vulnerable to inequalities. I think that it's very difficult for some people to navigate the NHS. I find it hard sometimes, and I've worked as a consultant for 11 years to navigate certain aspects of the NHS. And so, you know, accessing difficult asthma services can be really, really difficult. Going in and actually proactively identifying people takes away some of those layers of difficulty. And what we're hoping to run is a pilot here around Mid Yorkshire, supporting not only the identification, but people actually coming through the door with people like social prescribers and asthma champions from within our minority communities, communicating with people with that cultural competence, with that with linguistic skills, to be able to encourage them to come to clinic, so that we're not just identifying, but also encouraging people to come to us so that they can receive advanced asthma care when they haven't done so before. We've also acquired a Pathway Transformation Fund. It's a generous fund. I'm really pleased to have it. What we're hoping to do is co-produce with our community a suite of multilingual and culturally targeted information so that people can understand things in a way that's relevant to them. And we're going to do that with lots of different things in the next few months. We're hoping to pioneer some graphic medicine sheets. That's not just infographics, but a whole narrative in pictures. And we're hoping that will benefit not only people with language barriers, but also potentially people with learning disabilities, or just people who genuinely like to see things in pictures and remember things better in that manner. And those people are plentiful in all walks of life. We'd really desperately like to evaluate the current resources and the ones that we produce. And if you're interested as healthcare professionals in inputting, I'd love to hear from you. If you've got half an hour to spare, that would be fantastic. The other thing I'm passionate about, as I'm sure I've just mentioned, is educating communities from within. Lots of evidence suggests peer education is really helpful, and self-management can be helped by doing it that way. And so, like I said, we're building on the excellent COVID champion work that's been done locally and educating people and training people to become asthma champions as well as asking our social prescribers to undergo some training to help with asthma care. What we'd love to be able to do at the end of all this is acquire some actionable information. I think that this is a difficult thing, but we haven't got lots and lots and lots of data yet to understand the hows and the whys, and we'd like to have some data to guide targeted interventions, and also hopefully have some helpful metrics at the end of it all so that we can evaluate our successes. I'd like to say thank you for listening, and what would be lovely is that we continue to work together so that we can end the distributive injustices that we come across and the lack of equity of care for our asthma patients. Thank you.
Thank you very much, Klanos. Is that a picture of your house at the end?
I wish it was. Our house is like the house that Jack built and that needs lots of renovating. But it's from the pandemic. Do you remember the Avra tutto bene? It's what the Italians used to send out to us to say everything will be all right in the pandemic, Ian.
Fantastic. Thank you very much for that, Klanos. And so moving swiftly on, so next up is Dr. Sunil Kansara, who's a consultant in paediatric respiratory medicine in Sheffield, who's going to talk about the National Bundle for Care for CYP asthma.
Thank you. I'm just trying to load my slides there. Okay, hopefully you can see my slides.
Yep, just needs to go on slideshow.
I have clicked slideshow. I think it's just taking a little while to go on there.
You might need to click it again because it still hasn't done it. No. We can see them, just not in slideshow mode.
Sorry, we thought we were all getting very good at this, but clearly there's
just one of those things.
Learning curve to get to. Okay. I'll probably not waste your time. If it doesn't work, are you happy for me to continue like this?
Yeah, just carry on with them. They're still not on slideshow, but if you just scroll through them, we'll see them.
Okay. Thank you, Professor Sabrero. I'm really grateful for the opportunity to come in and speak today to an audience, which is representative of whole of Yorkshire, and I do feel there are not many pediatricians there, so hopefully I can make the case for why children are important when we think about asthma in the population, and how we work as a system to bring about that change, and to that effect what the work the National Bundle of Care for Children and Young Persons with Asthma is intending to do. First of all, why should we get it right? Are the slides moving?
No, You'll need just to scroll down through them.
Right,
Yeah, we've now got your third slide. That's fine. Yep.
So this is a study looking at the various trajectories of lung growth. And really the reason I put it here is because in this study of around 1,000 patients who had asthma, who had moderate to persistent asthma, there's only 25% of children who went on to grow their lungs normally. And around sort of 18% of these children had lung functions which would be consistent with COPD by the time they were in their 30s. So a lot goes on in childhood, and if we are going to aim for good health in adulthood, we need to start early, is my pitch there. And things aren't, brilliant at the moment, and you highlighted this earlier as well. We've got one of the worst outcomes in terms of mortality in the under 24 population. Whichever age group you look at, we are right at the bottom in the blue. The asthma is common, and it's like 1 in 11 children, and you would then expect around 2 children in every classroom to have asthma. So it is very common, and that's why it's really important that we know about it and we start looking at asthma outcomes in children. There's a very high healthcare utilization. The exacerbation rate needing hospitalization in all groups is highest in the 5 to 12-year age group. So a lot of unscheduled care in this age group of children. Huge impact on education and school, needless to say. On an average, not adjusting for the severity of asthma, a child with asthma misses 2 full school days as compared to his peers. Okay, so it has it has a huge impact there. And then there is an impact of the adult behaviors, which I will come to in a minute. There is dependence on adults for our health needs when children are younger. So very much they don't choose not to come to the appointments. They are not brought to appointments. They can't really choose where they live. They can't really choose whether their parents smoke. They can't really choose whether they walk to school. It is a lot of what happens in adult behavior is what impacts children. And then when they start taking a little bit of responsibility, there is a lot of risk taking in adolescence, and needless to say, underlying what if you are from an ethnic group or you are from a socioeconomic strata, which puts you at high risk of poor respiratory health right from the moment you are born. We did a little bit of work around this with colleagues in our area, and we came up with this fishbone diagram of how we'd like things to be and what are the barriers to this. And essentially, what I like to say is that this is very much South Yorkshire and very much what we were seeing as problems. But these aren't problems which we can solve on ourselves. These are very much system-wide problems which need a system-wide answer. Luckily for us, this year, children and young people's asthma is a priority program for transformation in children and young persons' health generally. And the team nationally has come up with a bundle of care to improve several components of the asthma pathway, and that has come with some funding at the integrated care system level, the level where we want to work and make a difference. And actually, most of the elements of this you can probably recognize from the Finnish study you put up earlier. So environmental impacts, making the diagnosis properly, putting in place self-management strategies, having, you know, a harmonize between exacerbations, various places where children seek help for acute exacerbations, and then on the other end, the severe asthma. You know, we probably have less biologics in children, but and a lot of times the studies in children are not there. The evidence base is not there, and children are a bit of an afterthought. So there's a lot which needs to happen, but not very different from how people have achieved success in the in other countries. And I'm happy to see that all these factors are recognized in the National Bundle of Care. And then there are some overarching themes there, and that overarching theme is data. So under good data collection, which then guides us where to put in the intervention, and about education. Education not only about patients, but also people taking care of children with asthma, starting right with school teachers, scout leaders, or social workers, right up to making sure that we have standards for people caring for children with severe asthma. So a framework of competencies around education of people who help in taking care of children with asthma. That seemed a lot to do, but our approach in South Yorkshire is really to try and find out what is already there, and there was already sort of quite a few things which are going on, and we're hoping to pull that together so we can get a system-wide approach going to help children and young people with asthma. There's a QUIT program. The research team up at the Children's Hospital, we're already setting a website with patient information sort of targeted at adolescents, which sort of talk to them in the form of rap songs and things to try and get them to get more, know a little bit more about asthma and know how to manage it. And then we have the benefit of having a website sort of dedicated to children and young people, people's health in South Yorkshire, which we're hoping to call upon to get our message through. It's been a lot of talking to colleagues all over the system, in education, in pharmacy, in primary care, in secondary care, trying to understand what the picture of asthma is. And we're in that phase where we're building connections so that we don't duplicate the work, rather we can complement the work together. Now, we picked up a few things which we can do easily, which were, while everything else became a little bit more clear to us, and we've started working on uniform asthma plans for children. We've set up these educational resources which will be accessible to children in a format where they can relate to them, TikTok videos, and again, things where we could make a difference in terms of asthma-friendly schools. A lot of good work gone on already in the Leeds area, where we're sort of looking at inspiration from and getting education into the conversation. So yeah, we're at the start of our journey, and me talking to you today is to advocate for children and say that children and young people's asthma is also an important part of improving respiratory health, of improving asthma outcomes, and should be really a part of improving asthma care in Yorkshire. We have some challenges, and we've in terms of there's been lack of clarity about incentives. There will be there's some disagreements on what hub should look like. The ICS boundaries are very poorly aligned with the referral patterns of children, and there are some teething issues. But I think nothing which we can't particularly work around. So I'd like to stop there and say that children and young people are health is an important piece of the jigsaw, and we're taking a system-wide approach with some national direction, but very much we will make it very much Yorkshire-based. And call upon our local resources to address that. Thank you.
Thank you ever so for that. I seem to have transiently lost sound from Ian, so we'll hand over next to Shoaib Faruqi from Hull, who is going to show how we can think about identifying patients using new tools to see who actually we need to be targeting for more intervention. Hey Shoaib, we can see you, but you're muted and we haven't got any slides yet.
I should be unmuted now.
You're unmuted now. Awesome. All we need is slides.
Progress in life,
or
yes.
just your beautiful face.
Well, that I can stop the video if I'll share the slides in a second.
I'm glad to see Ian back. Apparently Teams threw him out. Wasn't our doing. We love you too much.
I'm assuming the slides are actually set now.
Just need them on slideshow, but
Yeah.
otherwise they're there. Perfect.
Excellent. Technology works.
Yeah, although actually we've got your presenter view with your next slide showing on the side, but it doesn't really matter.
No, it doesn't matter. I agree. So I was going to talk very briefly about well, how we can see more patients with severe asthma and what we can do about them really. And I thought I'll first cover what is severe asthma, which is as per the consensus opinion from 2014, which is when a diagnosis of asthma is confirmed and comorbidities addressed. Severe asthma is defined as asthma that requires treatment with high dose ICS plus a second controller and/or systemic corticosteroids, either to prevent it from becoming uncontrolled or that remains uncontrolled despite this therapy. And of course, those in the severe asthma fraternity would know that severe asthma also comprises difficult asthma, wherein factors such as adherence, comorbidities, psychosocial factors, triggers, etc., may contribute to poor control. And it is when the above are addressed that asthma remains uncontrolled, perhaps it could be thought of as severe asthma. And it is important to consider severe asthma because although only around 5 to 10% of all asthmatics will have severe asthma by definition, more than 50% of asthma-related healthcare costs are applicable to this group of patients. And we also know that increased frequency of exacerbations impact on quality of life and adverse effects on drug therapy. And the kinds of patients we would want to be, which would want to see in secondary care are those who are requiring either continuous frequent courses of oral corticosteroid, those who have had life-threatening asthma and required being managed in an intensive care facility, those perhaps with fixed and worsening airflow obstruction. And at the bottom of the slide is the standard BTS algorithm for management of asthma, and the rightmost column suggests that when asthma remains uncontrolled, we should refer them for specialist care. So that is a little bit about severe asthma and and the kind of patients we would like to see in our clinics. From now onwards, I'll move on to some data about the pathway itself and some local projects which we've done in Hull, which might engender some conversation. So this is data collected across 17 severe asthma centers throughout the UK, and as you can see, in more than half the patients, there was a wait of up to 2 years prior to being referred into a severe asthma center. And even when they do get referred into a severe asthma center, there are, as can be seen, very clear delays. Hence, I think there is scope to improve the pathway for patients with severe asthma, both from primary care into secondary care and, of course, into secondary care itself. As far as how uncontrolled patients may be identified, there are several algorithms, help available, and I've listed some which are freely available for all to use. So I suppose the question is not really how we identify patients, but the question is what we do about them. Because clearly, if we identify patients with uncontrolled asthma, severe asthma, we clearly have a duty to do something about it and manage them better. So from that perspective, I will discuss some experience we have gained in Hull from projects which we've been doing for the past few years. This is a rather busy slide, but this is the results of a project which we had undertaken in primary care a few years ago. Actually, I think it was June to October 2019, when the asthma service from the hospital undertook clinics in general practice. So 3 general practices, 7 clinics, and we identified patients who had frequent SABA use, which was more than 6 courses per year, and recurrent courses of prednisolone, or poor symptom control. And we did actually go into these practices, and the patients had a spirometry done, had FeNO levels checked, they had inhaler technique assessed, they had a specialist nurse review and a physician review, which is all well said and done. But of course, we don't have these resources in primary care itself. But if you can see from the table, a significant proportion of patients did not have an up-to-date asthma action plan, and inhaler technique was also not checked in the past year for a significant proportion, and hence there are simple interventions in primary care itself which might help with asthma control. If you look at it from the perspective of these severe asthma patients who perhaps may have progressed to biologics, around 10% or so of the patients we had identified could potentially go down that route. And overall, the conclusion was that community outreach service may help in management of severe asthma patients. However, it does come with resource implications. I'll move on to another project which is ongoing here in our region, and indeed it has moved on on a wider scale nationally as well. This is the Sentinel Project, and this is being led by my colleague here in the asthma service, Michael Crooks, who I don't think is taking part in the meeting today. And the aim of this project was to improve outcomes for adult asthma patients through both identifying and addressing SABA over-reliance. And we wanted to implement our local guidelines here. And the second part of the project was, if we were to reduce the over-reliance on SABA, then it would have an environmental impact as well. So looking at moving on to the results of the project itself. So 23 practices completed this, and there were over 16,000 patients assessed for this. And 38% of asthma patients had 6 or more SABA issues in the last 12 months, which clearly is a big number. And this is an interesting graph at the bottom. If you can see this, the bluish squares reflect that increased corticosteroid courses do correlate with the increased number of SABA prescriptions as well. So these are people with possibly severe asthma and who may benefit from review. And so far there have been more than 2,500 patient reviews as part of the project, and the proportion of invited patients with a consultation is around 46% so far. And just a quick slide to demonstrate the decrease in SABA use. So on the left hand corner, left hand to this line here is SABA use prior to the start of the project, and this is where we are at present, which is clearly, well, at least in my opinion, an excellent outcome. I'll move on to another project which we are undertaking at present in secondary care, which is wherein we are looking for possible severe asthma patients who have been through the hospital but have not been identified. So SQL is a structured query language. It's a computer language quite commonly used in various softwares. So we used SQL, an SQL-based algorithm to run on our patient administration database to identify patients who were active in secondary care between October 19 and September 2020, who had a diagnosis of asthma, were adults, no record of death, no record of COPD, and no record of referral to a severe asthma center. And when we did run this search, we classified them into 3 groups, one in order of perhaps severity of the asthma itself, which would be 3 A&E attendances, 1 A&E attendance, and so on. If you look at the results, we identified 129 patients. However, 90 were already under follow-up with us, and this really came about mostly because of an inability to recognize patients who were under home care or had been to a medical day unit for initiation of biologics. And there was duplicate data for 5. However, we did identify 26 patients who were not under follow-up, and these will be reviewed, and possibly some may progress to biological therapies as well. Lastly, I'll come to another project which we are undertaking at present, and going back to, can we identify patients with perhaps who are or patients or areas with perhaps some inequity of care? And the answer is yes. So these red circles identify areas wherein patients have been prescribed 3 or more courses of oral corticosteroids, and where there haven't been referrals from into a severe asthma center. And if you look at biological prescriptions itself in our area, which is the Humber Coast and Vale ICS, in the Hull and East Riding CCGs, the proportion of asthma patients on biologics around between 0.3 to 0.4%. However, in some areas surrounding Hull, this is the proportion is 0.04 to 0.13%. So we thought it would be an idea to undertake a project in which we could identify patients from these areas to see if we could provide reviews firstly in primary care, and then, if necessary, see them in secondary care. So primary care health records will be searched as part of the project, with patients with severe asthma identified on the basis of 3 or more courses of oral corticosteroids or maintenance corticosteroids in the past year or so. Once these patients are identified, case notes will be reviewed, and patients would be agreed for a clinician review. If there is no biomarker available, such as eosinophil count, this will be arranged, and there will be up to 3 reviews in primary care itself. And if asthma still remains uncontrolled at that point in time, then these patients will be referred to our asthma service, and they will be reviewed as would any other patient referred with asthma. The idea being then discussion and treatments as appropriate. So this project has just about started, and we wait to see what the outcomes of this are. And at some point, I'll be more than happy to take questions about this.
Thank you very much for that. And I think, as you point out, we sometimes need to go out and find the patients to address some of these inequities we've heard about. So moving on swiftly, I'd like to welcome Toby Capstick, who's one of our consultant pharmacists here in Leeds, who's got a particular interest in inhaled therapy, and is going to talk about MARTs and PRN ICS labbers.
Okay, hopefully you can see my slides.
Yep.
Brilliant, thanks, Ian. Yeah, so thank you for inviting me to talk about MART and PRN ICS labber. And I think firstly we want to put this into context about why we're interested in this. If I can get my slides to move on. Is that moving on?
Yep.
Good, because I can't see anybody now. Yeah, so one of the main reasons is overusing of SABA inhalers. And this is one of the things that kind of gets me with all the environmental discussions, in that actually people are using it as a reason to switch people from their maintenance inhalers. But when we look at prescribing data for England, we see that 2/3 of inhalers prescribed are MDIs, and 60% of those are SABA. So you can see from that chart, really, when we're targeting steroids and ICS labber inhalers for switches, actually what we're missing is a SABA overuse. And nationally as well, what we see is that 22% of asthma patients are using at least 6 SABA inhalers a year. Now, good asthma control is using your SABA no more than twice a week. So a 200 dose salbutamol MDI should last 50 weeks. So somebody who's using more than 2 or 3 inhalers really does seem to be particularly overusing. And we know that from the Sabrero study, anybody who is regarded as a high SABA user, this is people who are going through at least 3 salbutamol inhalers a year, they have a twofold increased risk of asthma exacerbations compared to low users, and that is seen at every step of the BTS guidelines. And when we're seeing these exacerbations, it includes GP visits, includes hospitalizations, and we know an overnight stay in hospital with an exacerbation of asthma has the same carbon impact as 5 Ventolin MDIs. So when we're switching people without checking their technique or getting on the right therapy, we increase the carbon impact potentially. So single inhaler therapy, so MART and ICS lab, PRN ICS labbers, these are really being promoted internationally by the GINA guideline. And in recent years, they've separated their stepwise algorithm into 2 sections. At the top, which is the way that they prefer people to go at the moment, is to use MART therapy and PRN ICS labbers. You can see steps 1 to 2, as needed, low dose ICS for motorhome. And then step 3 and 4 is using your MART regimen, so that's in maintenance ICS labber plus PRN. And then the traditional fixed dose maintenance inhaler with salbutamol reliever is at the bottom, which is an alternative regimen. But they think single inhaler therapy is the way to go. So why are we thinking about this? So what's the rationale? So this is going back to the facet study. So a long time ago, when I was still at university, that's how long ago it was. And looking at the facet study, they tracked actually, or they described the patterns of an exacerbation. And if we take day 0 as the point of the exacerbation, you can see in that run-up, in the days leading to that exacerbation, we see peak flow scores are getting worse. Symptoms in the daytime and nighttime symptoms are getting worse, and they're tracked very well by proportional use of rescue salbutamol inhaler. And really, salbutamol isn't actually preventing an exacerbation because it doesn't treat asthma. We know that. And the thought is actually, if we can target somebody in the early stages of deteriorating worsening control, we might get to a point where actually we can stop that exacerbation. And the way to target somebody there is with an asthma treatment, which is your steroid. So that's the theory. If we can give people PRN, ICS labber, you're going to get an extra dose of steroid, can hopefully improve the asthma control and get things coming back before you get that bad exacerbation. So let's look at some of the data, and there's lots of studies to quote, and I'm just going to show a fairly recent systematic review and meta-analysis, and this included 16 randomized controlled trials, nearly 23,000 patients. And they've looked at using MART therapy, so twice daily or 2 doses of 2 doses of your ICS labber plus PRN versus your traditional maintenance dose. And they've looked at same dose ICS labber, and they've looked at comparing to people on higher doses of ICS labber. And those are the 2 charts that we can see. So the top one is people on the same dose ICS labber comparison versus same dose ICS labber. We see a 32% reduction in exacerbation rate. At the bottom chart, we can see quite clearly again, compared to giving people higher dose, fixed dose ICS labber, again, 23% relative risk reduction in exacerbations, which is really, really important. So actually, these seem to work compared to ramping up the ICS dose, and that'll help reduce side effects from your steroids. Now, looking at the other outcomes, because it's not just exacerbations that we're interested in, we look at the top chart here, the asthma control questionnaire score. We can see there's really no significant difference in asthma control by using MART regimen compared to fixed doses, a trend towards a better asthma control. In the middle, lung function, okay, it looks like there's a trend towards improved lung function with maintenance, fixed dose maintenance ICS labber. And then we can see at the bottom, again, no significant reduction in rescue medicine use. And in trials, generally people are using no more than 1 additional dose of the ICS labber a day. So that potentially is about 3 ICS labber extra inhalers a year, which, okay, there's a significant cost with that, but compared to the cost of a hospital admission is insignificant. So it does look to be a valid treatment option. Now, moving on to the as needed ICS LABA, and the only studies really I've seen are in Symbicort, so budesonide formoterol. And so this is a Sigma 2 study. So this is comparing PRN use of Symbicort compared to fixed dose twice daily Pulmicort Turbohaler with PRN Bricanol. And the theory behind this study is in your asthma patients who've only got mild asthma symptoms, what we often see is they don't use their inhalers when they're well, and then they might use it when they start to get their worsening asthma control. And if we accept that that is normal practice, because normal health behavior, because if they're well, they're not using it, then actually let's see if it works. And what we can see is in that top chart, annualized rate of severe asthma exacerbations, there was no significant difference in the rate of severe exacerbations. So rescue steroid use, hospitalization, or A&E visit. And in the bottom, the time to first severe exacerbation, you can see it tracks very closely. There's no difference in time to first exacerbation. People on PRN Symbicort were using lower median steroid doses overall, and similar use of PRN use of Symbicort compared to PRN Bricanol. So this seems to be another reasonable option. And we can see again, looking at asthma control and look at the percentage of well-controlled weeks, you can see that the blue is PRN Symbicort, and then red is, blue is PRN Bricanol only arm. You've got red is the PRN Symbicort only arm. We can see very similar well-controlled weeks. If you have fixed dose budesonide, you have a slightly higher proportion of well-controlled weeks, but maybe it's not particularly significant. It does seem to be an option, but it's not actually licensed in the UK at the moment. So just as a quick summary, maintenance of reliever therapies, low dose, medium dose ICS LABA, it seems to reduce exacerbations, no particular effect on lung function, asthma control, rescue medicine use. PRN ICS formoterol seems to be, again, reduction in exacerbations, but it's not licensed in the UK. And people on average were using 3 or 4 doses a week. So it does seem to be an option. So what inhalers are currently licensed? They're only licensed for MART therapy in the UK. You can see there's the budesonide formoterol, Symbicort, and a range of generics. You'll see there's a Symbicort MDI. I've asterisked that because it contains HFA 227, which is a very, very high carbon impact. So just don't use that at all. WACAIR, I've highlighted again because that's owned by Vectura, who are now owned by Philip Morris International. So any use of WACAIR, you start paying the tobacco industry. We can see that Foster, again, is at the bottom. It has a lower maximum licensed dose, 8 puffs a day, compared to your budesonide can go up to 12 puffs per day, but most people won't need more than 8. And then anybody who's using more than 5 a day regularly, that's probably a sign it's not working for them. So very briefly, just to implement it, the priority, remember, is the patient. It's about achieving good control, preventing exacerbations, because any exacerbations, they have more inhaler use, more healthcare, more utilization, more admissions. People it might be appropriate for: high SABA users, frequent exacerbators. Think about people who've got poor inhaler technique. Benefits, there are environmental benefits as well by preventing exacerbations, reducing all this excess SABA use, reducing the number of inhalers used. And if there's one paper really to have a look at, this paper was published by Helen Riddell's group very recently, looking about how to implement MART to my patients. And they very much emphasize it's a shared decision making involving the patient, give an asthma action plan, and doing what is right for that individual patient. And in Leeds, we are looking at implementing Sentinel within our primary care as well. And I haven't talked about that because that's been done very well already. Thank you very much.
Thank you very much, Toby. And it's linking the environmental impact that you've alluded to in terms of inhalers. I'd like to introduce Dr. Arti Bansal, who's going to talk about a toolkit for high quality and low carbon asthma care. So welcome.
Hello. Okay, so I'm assuming that is not on the correct
Yeah,
Indeed, we can see your slides, but oh,
Yep.
Perfect.
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 Fine, got there. So thank you very much for inviting me to come and talk to you. And what I'm going to talk to you about is a toolkit that a few of us have been developing in primary care, which will be going live on the 1st of April to coincide with some new indicators that come out for primary care. And we've developed this toolkit to help general practices actually implement what we've been talking about today, which is high quality asthma care, but also see if they can reduce the carbon impact of that, as Toby's been mentioning at the same time. And just to say that this toolkit has been reviewed and approved by the NHS England and NHS Improvement Inhalers Working Group as well. So as people have been saying today, you know, we really ought to be thinking about improving the state of asthma care in the UK. Our death rates are some of the worst in Europe, and it's thought that at least 2/3 of asthma deaths are preventable. And if we look at our inhaler device prescribing, we use more metered dose inhalers than most places in Europe. And as Toby's mentioned, most of those inhalers that we're using are actually the salbutamol or the short-acting beta agonist inhalers rather than the inhaled corticosteroid inhalers. So why is this an issue from an environmental point of view? Well, it's metered dose inhalers contain propellant gases. These gases are 1,000 to 3,000 times more powerful than carbon dioxide equivalent, which means that even though they're only small little devices, they actually account for 3% of the NHS's carbon footprint and 13% of the GP carbon footprint. And you may know that the NHS declared in October 2020 that because the WHO and the Lancet and others have declared that the climate crisis is the greatest health crisis facing us in the 21st century, we became the first health service to say we need to move to net zero. And so we now have indicators to try and help us to do that. But of course, as Toby's mentioned, the most important thing that you can do to reduce the environmental footprint of asthma care is to make sure that people have good care. And if they have good care, they're going to be reducing the amount of inhalers that they're using inappropriately, especially SABA overuse. And I guess the thing is to say, is the patient on the most appropriate inhaler that they can and they will use? The truth is that in primary care, we haven't been offering people a choice of different types of inhalers. They have just by default been getting metered dose inhalers. But actually, a lot of patients may actually prefer a dry powdered inhaler. Has a different technique. Not everyone can use it. You need to take a quick and a deep breath, but it doesn't require a spacer. Often they come with dose counters, and most people can use them. So these are the contract indicators that are coming out of NHS England, and they're a direct enhanced service, so that means it's across the nation of England, and they're in both of these areas. So there are indicators around improving asthma care, so looking at patients on the asthma register who may not have been prescribed many inhaled corticosteroids over the past 12 months. So they're not maybe adherent with preventer therapy. Shall we have a look at those, make sure that we can get the number of people who are on regular preventer therapy up, but also looking at patients who might be receiving 6 or more SABA inhaler prescriptions over the previous 12 months. The other speakers have talked about how that is linked to poorer outcomes and trying to reduce the percentage of those patients. And then there are also indicators around reducing the carbon footprint of inhalers. So we saw that slide earlier about how we prescribe far more metered dose inhalers than other countries in Europe. So can we safely and effectively reduce the proportion of patients who might be on a metered dose inhaler? And also looking at salbutamol inhaler prescribing, and that's because even if somebody's needing a metered dose inhaler for their short-acting beta agonist inhaler, there are differences between the type of inhaler. So for instance, Ventolin has 28 kilograms of carbon dioxide equivalent per inhaler, whereas Salamol and Aramir, which are also metered dose inhalers, have around 10. And then if you used a dry powdered one, that would be less than 1. So there are changes that can be made just on that. So there's an indicator around that. But the thing is, it's very well to say, here are some indicators, but then we want a framework, don't we? We want guides, we want people to understand how are they going to do this. And as Toby mentioned, there are risks if we don't do this well. And so one of the things that we've done at Greener Practice, and Greener Practice is an organisation mainly of clinicians working in primary care that are concerned about sustainability and acting on sustainability in a way that improves patient outcomes. And so we developed this guide for our healthcare professionals, primarily in primary care, with this idea that, first of all, what we're looking to do is optimising asthma and COPD care. And then thinking about, can we offer a dry powder or a soft mist inhaler as a first choice where it's clinically appropriate. Then thinking about how we reduce the carbon footprint where people need their metered dose inhalers, and also talk to people about safe disposal so that those propellants don't end up in landfill into the atmosphere. And very much in terms of principles, looking at making sure that it's the right medication for the right individual, doing it in consultation with the patients as a shared decision-making process, making sure that we are focusing on inhaler technique, making sure we follow up patients if there's a change in device, and not doing any blanket switching. So we produce this guide, but that's not enough, because we're all really busy in primary care. We're, you know, as people are across the healthcare system, we're often doing care in 10-minute slots. And it's really important that people have support to actually make the changes that they need to make. So we thought, well, okay, what do people actually need to do? Where is the quality improvement needed? And we thought about all the different areas in general practice where we might want to improve the quality of the care that's provided. So your asthma patient is going to potentially, the first time they have symptoms, they're going to present to a GP. We need to think about, how do we code suspected asthma? How do we make sure that they're being followed up? They don't just end up on a blue inhaler and not go through the process of diagnosis. But patients also request repeat medications, and they might come into contact with receptionists or pharmacy. And how is that process being looked at? What happens at medication review? What's happening at your asthma annual review? And what do we do when a patient might need to attend hospital, and then we get a letter through? What do we do about coding that? What do we do about following up those patients? And we recognise that actually we need a whole team approach to quality improvement. So if we're going to do this well, it's important that it doesn't just land on our practice pharmacist's desk or our asthma nurse desk to do this, but actually there's a whole team approach to it. And so what's come out as a result of that is a toolkit. And what we've done in this toolkit is that we have divided up the projects into these four different areas: diagnosis, disease control, device, and disposal. And within that, we will have educational resources. So there'll be 10-minute educational videos, and we've got people who are experts in the field to give us the knowledge, so that clinicians on the ground have the knowledge about up-to-date guidance on what do they need to know in terms of diagnosis, what do they need to know for disease control, about device choice and disposal, and always making sure that we're integrating the high quality care with the low carbon care. So there's educational resources, and then there are step-by-step guides, step-by-step projects that people can do in any of these areas. So people could have the options of which projects they're going to start with. And within the resources, there's also searches, there's templates, there's prescriptions and templates, there's SMSs you can send to your patients, emails. I'm going to show you a few of those things. So it was really good, actually. Actually, let me just tell you about, this is just the idea of the step-by-step guide. So really helping people to think about, okay, if we're going to improve what we do when somebody requests a SABA, think about which are the staff who are involved in that. Do they need to understand where to look to identify how much SABA this person might have already used? What do they do if they find this person's having high SABA use? Do they maybe prescribe it at that point, but then send them more information, send them out an invite for review? And we're really trying to break all of these steps down to make it as easy as possible for clinicians on the ground to do this work, but to do it safely and effectively. This is just another example of the step-by-step guides of how people are going to look to find things like SABA over-reliance. And then we've created sort of almost pre-written messages that people can use. One of the things that happened in the pandemic is we started to use systems in primary care like Accurix for sending out people information with text messages, and I don't think that we're going to go back on that. We're going to carry on using that, and that can really help with giving people information before an appointment, giving them information after an appointment. So, and these can include links, so they can include links to other resources that can be really helpful in empowering patients and educating them. Now I'm looking at this and I'm hearing Clinos say, have you thought about the functional literacy of those 1 in 6 patients for whom this might be really wordy? And yeah, we have thought about that. I don't think this is going to be the best patient information leaflet for all of our patients with asthma. And we are also creating videos which say the same sort of thing. So this is one on inhalers and the environment. As you can see, we've put right at the beginning there, good asthma control is the most important thing. We've also got one just generally about what is asthma and what kind of control you should be thinking about. So those can be sent if we identify patients with SABA over-reliance. But we've also got videos which are hopefully going to be much more helpful for those patients. And Clinos, I'm really pleased to hear that you're going to be creating resources for patients in different languages, and we'd be very happy to link those in. And any sort of resources, Sonal, that you have for children, would be very happy to link those in as well. So finally, just wanting to say, okay, so you've got the incentives for primary care, you've got a guide which gives you a framework and principles, you've got a toolkit, but I'm not sure even that's enough. So one of the things that I hope that is going to come out of this summit today is thinking about how are we actually going to give clinicians on the time, on the ground, the resources that they need to implement high quality and low carbon asthma care. And I think one of the things that we need to think about is educating everyone, so everyone's on the same level and up to date, for instance with MART therapy that Toby's just talked to us about. And we need to think about integrating content and process, so people need to understand the disease control information and the carbon footprint information, but it also needs to be integrated in ways that people generally receive. So multidisciplinary teams in primary care accessing maybe protected learning time, this needs to be at the top of the list. We also need to communicate the resources that are out there and make sure that they're as available as possible. But I think we also need to give people protected time to actually do the quality improvement work, and we really need to seriously think about how we're going to resource the clinical champions who are going to do this quality improvement work in practice. And as Clinos said, and as Catherine said at the beginning, we absolutely need to involve our patients, and we need to involve the medicines optimization teams. And that's it from me. Thank you.
Thank you very much for that, Archie. It's very interesting, and I think clearly a hot topic at the moment. So finally, we leave the best for last, and it's my pleasure to welcome welcome back Ian Sabrero, who is a Professor of Medical Humanities at Sheffield, and as many of us know, a real champion of asthma care in West Yorkshire, for looking at advanced therapies for small numbers of patients. I was going to say small patients, but no, small numbers of patients.
Just small doctors. I presume you can see my slides, I hope.
Yes.
Perfect. I'll be very brief. But this is the thing. Part of the reason for bringing the summit about was those of us now that work in secondary care have these kinds of conversations with our patients. I've had a few of them this week. They come in and they say, "You have changed my life, doctor." And there are very few opportunities for that to happen these days. But these new biological therapies and the advanced therapies that we can provide change people's lives dramatically and in a transformative way. The challenge is that what we need to be able to do as a region and as practitioners working across primary and secondary care boundaries is actually be able to deliver this. And it's about identifying individuals, their needs, and meeting their individual needs, which we currently do badly. And I think that the problem is we know that we're probably reaching less than half, maybe less than a third of the people who benefit from life-changing therapies. And we need better ways of getting our systems together so that we find, identify, change treatment and change the lives of people that we treat. So it could be an 18-year-old woman, a 35-year-old man, an 85-year-old woman. There are no age restrictions, gender restrictions, boundaries. We want to transform the lives of people who have severe asthma. And I'm thinking of those who, for example, need frequent courses of steroids or multiple A&E attendances, have high medication requirement. We have the opportunity to be transformative in their care. The way that we do this is by thinking about what type of asthma they've got. You guys don't need to know this, but difficult asthma centres spend ages thinking about this, and we think about patterns that those of you in medicine may have done as cytokine biology, which cells are involved and how we can stop them doing bad things in asthma. But the most important thing is we have new toys and the landscape has really changed. What we have is a group of injection therapies, and there's an old one that some of you will have come across called omalizumab or Xolair that's been around 10-15 years. But now in the last few years, like the injection therapies for rheumatoid arthritis and inflammatory bowel disease, we have these injection biological therapies that completely change people's lives and are now becoming increasingly available for the care of people with asthma. In general, they're for people who need frequent courses of oral steroids or on continuous oral steroids. We have to go through an approved pathway, which is regulated by NHS England through the Yorkshire Asthma MDT, and they all had to be approved through a commissioning structure. So those of us that do this get used to paperwork, and we have a range of different choices. 10 years ago, I'd have only told you about omalizumab and we could hardly give it to anybody. Now we've got mepolizumab, and there's about 1,000 people in Yorkshire now on biologics, and we're only scratching the tip of the iceberg. That's not right, is it? We're on the tip of the iceberg of the people whose lives we can change these medications. In the last week, we've been given permission to use dupilumab, which is good for people with asthma, eczema, and possibly nasal polyposis. And over the next year or two, there's more on the way. We do this by working through approved assessment pathways, team working, careful assessment, and multiple levels of optimization of individual patient experience, by looking at the whole patient and understanding factors that regulate adherence, dealing with psychological factors, providing good education, thinking about inhaler technique, working through approved pathways and stuff. And then the key thing is, how do we get these drugs to people? Because it used to be that you had to come to hospital, which creates a massive inequity in case you hadn't worked it out. So there's all this really good data that Hlinos has alluded to, which is that the further away you are from a centre, the less likely you are to get treatment. And we know that there are areas where we see fewer referrals in from primary care, where we see less referrals into asthma centres, and we have fewer opportunities to change people's lives. But even in Sheffield, I've got patients who have an hour's journey on 2 buses to come and see me, and it creates a massive inequity if they simply can't afford it for the reasons that we've heard earlier. So what we do as well is, by combinations of face-to-face and telephone assessments, we also then work to deliver therapies to patients. And as has been already alluded to, Yorkshire has been a pioneer of home care therapies in England, and we've been leading in the initiation of biologics for people with severe asthma in their own homes or at their places of work to reduce the needs to travel and reduce inequity. So this is the key thing that I think that I've heard today. We can change lives. All of us can change lives of people with asthma, but that's not about clever therapies always. We've got these for 1,000 patients or maybe 5,000 patients in Yorkshire who need them. Maybe there's another 4,000 we've not seen yet, but there are going to be somewhere around 500,000 people in Yorkshire with asthma. And changing lives for all of these people requires a different way of thinking. So changing lives is about addressing health inequities, the green agenda, pollution, housing, campaigning for environmental justice, and by working together better. It's about diagnosis and management at all levels, from primary care through to the highly advanced tertiary care level of care. And underpinning this, we just need better systems, because I had no idea of all of these initiatives going on today. I'm going to imagine that most of you didn't either. The Finnish study shows that by doing this, we can save lives, we can save societal impact of asthma, we can transform people's health, we can save money for our integrated care systems and create more opportunities for that money to go off and do other things as well. So I'm going to finish up there. I'm going to hand over to Ian to hand over to Dinesh and Catherine for chairing a discussion. But I think that we've heard some amazing examples that I didn't know were happening, about beginning to work out what things can be changed, but they're all happening in silos and pockets. And the question for today, I suppose, is, if we came together, what could we do? And if we came together, how would we do it?
Thank you very much, Ian, for that. And I say thank you very much to all the speakers today. I think they've provided us with some really fantastic examples of really innovative care that is clearly making a difference to our patients. And as Ian suggested, I think we need to look at strategies to take those fantastic examples and roll them out wider so that we can try and deliver high quality asthma care across the whole of Yorkshire, and maybe we end up being an example of a healthcare system that can be looked at nationally as delivering really quality asthma care and effective and efficient, isn't it? Because I think, and we all need to be mindful that there are going to be financial pressures coming into the NHS, and asthma care doesn't have to be expensive. Some of it is, but the basics, if we do the basics well, we can deliver very good quality care. So it's my pleasure to hand over to Dinesh Saralaya, who is one of my consultant colleagues in Bradford, respiratory physician who's got a long experience in severe asthma, and introducing back Catherine Hickman, who's, as we've heard right at the beginning, is a GP in Bradford who's got a particular interest in respiratory disease, and I have conspired with over the years on many things. So I'd like to hand over to them to start the kind of panel discussion, and really looking forward to it. Thank you.
Thanks, Ian. With Kat's permission, I'd just like to make a few comments before we start. And I think this is a powerful group, really, which can influence the way we look at asthma care we deliver. Now, I think the COVID pandemic, and I'm certainly impressed with what Klinos has done, and she knows my opinion on that. I think the health inequalities in asthma is never better demonstrated in a city like Bradford. The Bradford has very, very interesting data coming out. One, nobody has talked today is the air quality as deprivation index is higher. So we're doing a MRC funded project with the University of Bradford looking at air quality in crowded housing. And it does, seeing whether there's a signal. And I'm sorry to say, when in inner city deprived households, the air quality is much poorer than if you live in a very affluent house in, say, Ilkley, Addingham, or Skipton. So this is very interesting and something which needs to be looked into. Bradford, again, amplifies the health inequalities we see in Yorkshire. In certain parts of Bradford, the mortality is 20 years lesser. You can die 20 years lesser than if you lived in a more affluent postcode. And that is, an airways disease plays a very important role in that. If you then mix that with high smoking incidence, metabolic disease, as somebody alluded before, and then substance abuse, that gives you a lethal concoction of people. And then if you have coexisting asthma as well. So I'm sometimes bury myself in the trial world when we look at the ideal patient, but I have to emphasize that the data coming out of clinical trials often does not mirror the sort of patient that we actually see in an asthma clinic, which comes with all sorts. And I think one comment I have is that we need to move on from these groups as well to involve patients, as very much Klinos has done in her work, to actually asking them what they want when you actually treat them. So, for example, I'm part of a eosinophil steering committee for the whole of the UK. And one of the things that we have also suggested is playing a simple video in our asthma clinics, telling them in their own languages what asthma is about. But more importantly, when they're sitting anxiously to see a consultant in a severe asthma center, what next therapy is going to be discussed with them. Though we think they're very hopeful of this therapy, there's a lot of anxiety about going on a therapy where people don't know much about. And that is some of the things, I think, some of the pointers that we need to be looking at. And I think I've taken some time, so I'm going to hand over to Catherine as well, and we'll probably throw open the discussion to the floor.
Yeah, I mean, I echo everything you say, Dinesh, and working in Bradford, massively has challenges, but there are also challenges across the whole of Yorkshire. And I think what has been highlighted today, as Ian said, that there still remains this silo working, and that it's the silo working with organisations, but also the silo working within, for example, within primary care, within my own GP surgery, we are all working individually, and we can do educational events, but the trouble is people continue to do the same things over and over again, and actually the people who suffer are those patients, and we need to try and somehow work out how we can bring this all together. And I go back to that first image that I showed of that jigsaw puzzle. It really is about putting the pieces of the jigsaw puzzle together and starting with one piece, because every jigsaw puzzle starts with one piece, and start to bring all the pieces together. So anybody got any ideas as to how we're going to do that? The floor is open. I can't see hands. Ian.
I mean, I know I'm very relaxed about how all this comes together. The thing is, I mean, I remember thinking about doing this meeting, and then and the things I come with a secondary care perspective, and I see things only from my eyes, and we just need to see things with better eyes. So, I mean, from my perspective, we're going to have 3 ICSs covering the whole of Yorkshire. Is that right? Is it something like that? So it would seem to me that we've seen amazing examples of transformative care that could be built and linked across us. And the question is, if we picked, is it reasonable or right to pick 2 or 3 areas that we could all work together on that could be made a priority in an ICS and a priority in secondary care that could be focused on around, for example, identification, maybe diagnosis, onward referral, or however it might be, but something that will then create meaningful differences and be really valued by everybody that we treat. And I agree, building patients in, bringing the patient's voice as part of it. I would make a suggestion that maybe we have a series of working groups and that people say, well, I would like to help lead the ICS to deliver a green inhaler policy that runs across Yorkshire. And then suddenly the rest of the UK says, look at what Yorkshire's doing. And maybe we then have somebody else say, I would like to see what's going to be the best Yorkshire-wide formulary. Now, there's a big challenge. Or a Yorkshire-wide identification tool. And by doing that, I mean, then if we identify all the patients that secondary care has got to put on biologics, I can guarantee we'll need an awful lot more asthma consultants too. But I suppose I wonder whether that might be a way forward, but it's then, what do people think are the key priorities that we need to do? But the problem is I'm secondary care, and you may see it differently from wherever you come.
I mean, no, I mean, I think absolutely having, putting each other's hats on and seeing it from different perspectives is really important. I mean, one thing that we're doing in West Yorkshire, we have now got, a collaborative working group looking at West Yorkshire asthma and COPD guidelines that a number of us on this call have been on, and they will be, circulated for comment. And it was amazing how fast that happened. It was really just an idea, an email, and lots of people saying, yes, let's do it. And we met, and it's happening. And we gave ourselves, I think we gave ourselves 90 days to get, asthma guidelines done, not signed off, but done. And we probably will complete that. And actually, it's amazing how if the right people are in the room, then things can really.
I think
shift and movement within respiratory in Yorkshire.
Glynis, you had your hand up.
Yeah, I was just going to, I mean, I'd love to leave the meeting, and I'm conscious that time's ticking on really, with some sort of tangible plan that we formed maybe smaller working groups. And really what will be quite interesting, and you talked about sharing budgets and things, Kat. What I've found is that, I've done everything I've done pretty much spare time on a shoestring, sort of put the kids to bed and then start working again, or giving up my day off a week. And it strikes me as we've got some real energy and some real lived experience of working through some of these issues, but what resources are out there? How are we going to, this has to be sustainable, and especially if we're going to bring it out at scale, it needs to be properly resourced. I think we need to agree not only how that's going to be resourced, but also how we're going to measure things, because I found during the project that having metrics to not only target intervention, but also to demonstrate success is really important. So I think we need to build that in right from the start, really. But it would be lovely to hear from maybe some people who are involved in setting things up, how we may achieve that, because it has to go forward. This work can't just finish. It has to be sustained, I think.
Glynis, there is a very useful comment in the chat. Pamela Hancock says, use digital technology to help decision making, and have regular meetings for vision shaping and patient stories for clinicians and other patients. you need an overview through that people can see the joint aim. So I think that's a really important point, I think, is about keeping that. So I sometimes ask myself the question, what do my patients know? What is coming in the asthma horizon? What are we thinking as a group? I think we need to take it down to the patient level and ask their stories as well. Because when you see a lot of these asthma patients, and I'm sure everybody treating asthma has that, not only there is always an inner story for compliance, concordance. There are lots of other issues. Collecting prescriptions can be challenged for some people, and so there is always a patient story in that. I'm trying to read messages, Kath, from the chat because there are some good points coming out. And there's another.
I mean, somebody's just said, we have to remember to keep the patient at the centre of things, and absolutely, and it's just going back to that diagram, isn't it? That it was, people centred, right in the middle. Artie, did you want to come in?
Yeah, I mean, I was just going to say that I think if you look at how we're organising asthma care alongside how we're organising a lot of long-term condition care, we're basically tending to see the people who need us the least and not necessarily getting to the people who need us the most. And I think we need to really rethink our models of care so that we're really able to look at seeing the people who need us the most. The other thing is that I remember coming across a couple of years ago now, I think, something in the BMJ journal about exactly how much self-management advice, education, knowledge do you need before you're able to self-manage your asthma. And it was over 2 hours. Now, we have 20 minutes with a nurse on a yearly basis. Should we really be going to something like group consultations, twice a year? People will get their 2 hours. They'll also get the stories from the other patients. So you'll get real world advice about all the stuff that, has been mentioned here before that'll actually help people on their journey. The other thing I was thinking of is that I'm surprised that clinicians and patients, how few people expect good quality care from their asthma. Asthma patients do not expect to be symptom-free, and they generally reduce the expectations of what they can do based on their symptoms. They almost kind of expect to be a little bit easy on activity. I know I'm generalizing massively here, but I think we need to raise expectations and make a really clear explanation around asthma being an inflammatory condition that is treated with preventer therapy. Because what I think has happened over the years is in our efforts to make sure that people could self-manage when they were having an exacerbation, we've kind of ended up giving people the message, don't be worried about using your blue inhaler. Take out your blue inhalers. You can use it up to 10 times a day if you're having symptoms, but we haven't explained what asthma is and why it is important to take that, preventer inhaler regularly. So I think at a public health messaging perspective, but also clinician education, there are just some really simple things that we need to just be very, very consistent about. Sorry, I know I'm talking for quite a while, but there's one thing that, if we can do one thing that I would really like this group to do, is really help people with the diagnostic pathway. Because at the moment, because the NICE guidance, reasonably, I suppose, in lots of ways, is saying you must get those objective confirmatory tests before you diagnose someone with asthma. I think we've got an awful lot of patients who end up with a blue inhaler, suspected asthma, and then not sort of ending up on a register. And I think can we come up in Yorkshire with a protocol and a guideline of what we think is appropriate and reasonable to happen in primary care. And it may be that now we go to community diagnostic centres, that it's possible for us to do that. But if we're going to do that, can we be really, really clear about it? I know, Catherine, you've done some amazing work on this in West Yorkshire, but it'd be great to do something Yorkshire-wide on that.
So Sally Davis, you got your hand up. Do you want to come in, Sally, please?
It was just a question really of my naivety. I'm in that interesting position where my clinical pathway ties closely with Sheffield and South Yorkshire, but actually I am in Chesterfield and Derbyshire, and our ICS is going to be there. So I'm a little bit at arm's length from these discussions for some of the practicalities and going forward. And I just wondered, are there already respiratory delivery groups, or do you have expert advisory forums across Yorkshire? How is that set up, or is this the initiation of something new? Because we've got respiratory delivery groups across Derby, and hopefully in the next year, development of an expert advisory forum where I hope similar work would come under the umbrella of. And our latest data regarding health inequalities is just as shocking. I think it's probably some of the worst in the country, actually. So I am desperate to keep my ear close to the work you're doing. But yeah, our ICS covers 2 different clinical pathways. So Derby tend to then link to Birmingham and Leicester. And I can tell you guys, they don't get half as good a deal as I do with the MDTs and things. So big kudos to Yorkshire for starters.
Kat, do you want to answer that? Or
I mean, so certainly West Yorkshire, we have a West Yorkshire Respiratory Network that is very much in its infancy, and the plan to have a number of subgroups. And you know, I'm aware that with my Leeds and Bradford hat on as well, there are already respiratory network in Leeds and Bradford as well, and subgroups of those. I think one thing that came out when we started looking at universal guidelines across West Yorkshire, that actually there was so much commonality, and really there were so many guidelines out there that were all sort of saying very similar things, and it wouldn't actually take much to do some tweaking to get cross Yorkshire pathways and guidance, and I think everybody is screaming out for that in primary and secondary care, to have that, just that universal, not to have 3 different Asthma templates, you know, system 1 and Ardens and one that's been done by the practice, and nobody knows what to do, and suddenly everybody starts defaulting to what they've always known, rather than actually you're all sort of singing from the same hymn sheet, because that's not only helpful for the clinicians, but most importantly it's helpful for the patient, that they're getting that consistency from when they walk into their GP surgery, they go to A&E, and or they go into secondary care, that everybody is working from the same pathway, the same diagnostic pathway, the same treatment pathway, and the same self-management plan as well.
so I've got also see Patrick Heaton, who's got his hand up. Do you want to come in, Patrick, please?
Hiya. I think Catherine just got there first in terms of what I was going to say, which was really that I think sometimes you can be overwhelmed by the volume of new information, resources, papers, etc. that are coming out. I mean, I'm part of a CCG medicines optimization team, and I actually lead on respiratory for that team. But even I find that sometimes it's a struggle with the volume and trying to fit it in with all the other things that I do, because respiratory is just one part of that. And I think we really need to, as I put in the chat, we need to find a way to collaborate and generate and coordinate so that we're all doing essentially the same good things in terms of asthma and COPD, rather than, as Catherine said, having a whole raft of different templates, documents, etc. And I also just wanted to say, I think the idea about the self-management and having something along the lines, the sort of way I thought of it was along the lines of the educational component of pulmonary rehab, which, you know, as we know, has been shown to be an effective intervention. So I just wanted to mention that.
Catherine, I just had one point here regarding pathways of referral. I think Rob Doe had done a piece of work, certainly asked us in Bradford. Is that a model that we should adopt, where there is a template? Because referrals into severe asthma clinics still lack, apart from SABA usage and exacerbations, are still quite scarce in terms of the data that we are looking for, is actually compliance, concordance, and the diagnosis, because we tend to spend a lot of time going back into the history and how that asthma diagnosis was made. Should we take it that those pathways are going to get refined, so that we take it that when a referral comes into the, mind you, a lot of severe asthma services, I'm sure my colleagues will agree, also get their referrals from any attendances and from other consultant colleagues. But is that something which we should be aspiring to across the entire patch?
I'm smiling because, you know, I helped review that thing, that the template that Rob sent round, and I am a GP in Bradford living in breathing respiratory, and I still don't know where it is. And I still don't, I don't know where that's housed. And if I don't know where it's housed, then who does? And this is exactly the point, that in order for the patients to get into secondary care, the people in primary care need to know how to refer and use the right template. And again, if we use the right template, it means that the right information gets recorded that's useful for you. Because there's no point in a patient with query severe asthma ending up in your clinic who's had 1 steroid inhaler in the year and 52 blue inhalers, because that's not severe asthma. That's multitude of problems.
Kath, I'm sure my colleagues are really welcome. Sonal has got his hand up. The other thing, Sonal, is that the transitioning patients from pediatrics often have a different, target setting on how they manage asthma. And we see a lot of that expectation. So for example, I'll just give you an example. I have an 18-year-old transitioned into our severe asthma service who was being managed on a MART regime, but had only no steroid courses in the last year, but that transition was still into the severe asthma service. So I would have thought in that particular case, if they have got compliant and they're optimized, then they really don't need to be seen by us. They could be well managed in primary care. Is that your experience? And it'll be useful to get your thoughts.
Thank you, Dinesh. There is a difference in thresholds across pediatrics and adults. It's very clear. And we do face this problem exactly around the time of transition. What we've tried to do with our colleagues across at STH is that even if we didn't transition to you, we would give you some information, because we are separate trusts between the children and teaching, about those children, and they can still go back. They will still have the full ready, steady, go pathway, which means that you enable them to take care of their health. You build up those competencies where they know how to pick up their prescriptions and build up these the health behaviors they need to, and then they can go back to primary care. But because they've had that problematic past, let's say, or we do copy our letters, so there could be a record which is kept in case things were to relapse. Because one of the things I do find very different is the amount of input we are able to give. Then pediatrics, be probably a little bit better resourced as compared to you in the adult world, and we are able to give a lot more help to these children, and then suddenly that help then suddenly in charge themselves, and that amount of help is not there. So we prepare them, but you're right that some of them could absolutely go to primary care. The reason I had my hand up was ready to say maybe it's probably time to think of a respiratory strategy. In the work we've done in pediatric asthma, we've realized that we want to cut down smoking as well. But there is already a smoking program going on, and it's just about having that link. We'd like them to have good housing and not have damp and mold in their property. How can we link with housing to just get that information through? So maybe an overarching respiratory strategy which takes care of all these different elements is the way to go.
I think learning from the point, I think there are already 3 work streams, Kath, we could think of. Is one looking at the referral pathways and how we care for these patients in primary care. The second could be optimization of treatment, and 3 would be when they actually end up in secondary care, I think the secondary care pathway, thanks to the leadership of in Sabrero, we've got a very robust YAMDT with local network meetings, local MDT meetings as well. So today in Yorkshire, we're quite proud to say that we can't initiate a biologic till an MDT discussion and a robust discussion about that patient has taken place, which would include optimization, compliance, concordance. So we've got that. So maybe if we can bring all the 3 streams together, I think, and then bring in the healthy inequalities piece with Clinos, and because there are patches within, I'm surprised that Sally told that Chesterfield as well. So it's not where you see minority populations, but it's across the patch. And I think a lot of this is linked to deprivation as well. We could get very easily that information from councils to see map, and I'm sure we can work together on that. I've seen Lisa Chandler, and then Ian has got their hand. Can we go to Lisa, please? Because I'm also conscious that we got about 7 minutes left.
Hello, I'm Lisa Chandler. I'm a public health principal in Wakefield, and I work with Catherine and some of the others on the West Yorkshire groups. I think what I would just like to add is shared outcomes across a system have an amazing effect on aligning everyone's priorities and moving towards a single, you know, aim and getting the right outcomes for patients and also organisations. But the other thing I'd just like to say is that as someone who's been doing this for a very long time now and was part of the old Yorkshire respiratory group that looked at introducing the national strategy for COPD, we do need to remember that while, you know, we develop our pathways and we develop our shared guidance, that Yorkshire-wide, just like national, does need to be localised and have local voices involved in it so that people actually accept and adopt and take changes to heart. And that we shouldn't assume that it's because people don't know or don't understand that they don't do these things. Pulmonary rehab being a great example. You know, I talk to my clinicians, they all know pulmonary rehab's a great idea. They just don't have time to convince patients to get into it and to go. So just to ensure that while we look at doing a sort of a Yorkshire-wide stuff, we've got West Yorkshire-wide stuff we're doing, that we do also remember that we've got to win the hearts and minds of the people who are actually going to do the work as well. And I think that's one of the things that, you know, as someone who's been writing policies and pathways for 30 years, that we sometimes forget. We set them free, if you like.
That's a really important point, Lisa. Thank you. So Ian, you've got your hand up, please.
Yeah, thank you. I'm really grateful to Lisa. I think she made some points that I was really very keen to make. I smiled when we were setting up this meeting, and I was thinking, you know, here, this is a triumph of hope over experience. A new NHS organisation system will suddenly all work together and we can make things better. And how many times have we all been around these loops? But one of the joys is we can still pick up from all the previous episodes when we've not been able to make it work and do it again. And this is the very first time that a group of interested policymakers and clinicians have got together across a region of 5 million people and said, what could we do together? And that's still pretty special, the fact that everybody's attended here. So I think that what we could do with then is some expressions from people who'd be prepared to work together, and then see if we can think of some ways of creating Yorkshire-wide stuff that we can disseminate and work together to change. And I think that, you know, I do think that there's a real chance to do that, and this could be really exciting.
Thank you, Ian. So is there any of the final, I'm just looking at the chat, whether there's any, so there is Anita, so pretty much an agreement on what we've discussed actually. So in terms of where we go from here next, I'm looking at Ian, Catherine, we are going to take this work along the discussion that we've just had.
Yeah, and I think sort of echoing what Sonal was saying about, you know, having a strategy, but I suppose before you've got the strategy and you think about what metrics you need to measure, we do have to have a clear vision, and that vision almost like has to be a golden thread running through everything, and you know, come together, get that vision right, and then the rest is easy. Not easy, easier. But I think sometimes we can jump in with all the ideas and the different projects that we're going to all work on, but actually all singing from the same hymn sheet and having that clear vision is really key.
Agree.
So I'm conscious of time, but I'm going to use this last 3 minutes or so, if with the permission, and I think certainly I've got Ian Clifton's go ahead, is to pay a tribute to Ian actually. I think I'm probably qualified because I may be the next in the line after Ian. So Ian, a huge thank you from all of us within the asthma community in Yorkshire. I think I've already made my thoughts very clear when we met at the YAMDT, but for people who don't know this, when the YAMDT was in its infancy, this was way back when newer biologics were commissioned, Ian single-handedly brought this whole large county together. The more important piece of Ian's work has been around ensuring that our patients across the county have access to this specialized treatment, and that is no mean effort. It's also of great credit to him, and he'll never tell this, is the way that he has galvanized that group to meet regularly prior to the pandemic, to ensure that these complex treatments are available across the patch in Yorkshire. And the tremendous amount of work that he's done in asthma care and the support. I know for sure, because I'm sure Klinos will second this, the amount of work that he has helped Klinos in delivering the excellent piece that she's done around the equalities and the translational stuff which Klinos has done for asthma biologics. So Ian, thank you. Thank you once again. It's been a real honor working with you, and I'm sure this group will probably carry on its work. We'll also keep in touch and invite you again. And you know, as I've told for the YMDT, you're welcome anytime, because your wisdom will always be needed.
I really appreciate that. It's very kind of you to say. So for those of you who didn't realise, I'm retiring, so hence I think. But thank you, Dinesh, for saying that. I really appreciated that. But you know, the joy of everything else, and I can't claim credit for the YMDT. That was me. That was Ian Clifton and I working together and bringing together everybody else as a complete team. But you know, seeing one of the nicest things, this is one of the last events that I'm doing, and actually leaving knowing that people want to work together to make asthma care better for the people that we care for is what it's all about. And my favourite ever quote is, I can never quite pronounce his name properly, but Rabindranath Tagore. I slept and dreamed that life was joy. I awoke and saw that life was service. I acted, and behold, service was joy. And we have a chance to continue to serve our communities and make the world better. So please volunteer for stuff. I'm going to suggest that Harriet sends around some emails just to encourage some volunteers. I agree that we get the vision right. We think about changing care better for Yorkshire. We work out what it is we want to do together, and create some simple tools that we can all apply based on the experience at Hull. We combine green inhaler strategies. We work together for some formulas. We advertise what we can do. We make those therapies accessible, and we can make people's lives better, and we can have Yorkshire as a leading example of how you can work collaboratively as a friendly county that aims to serve its patients better.
Thank you.
Pressure, everybody.
Thank you, everyone.
Thank you.
Yeah, thank you very
Time
much.
for us all to get back to the chaos of the day, but it's been lovely seeing you all. Thank you.
Thank you.
Thank you.
Bye.
Thank you.
Thank you.